Saya dari Pasti Kawasan Mesut ingin memohon sumbangan untuk pembinaan pasti. Untuk pengetahuan muslimin dan muslimat, sebanyak 7 buah pasti yang masih dalam proses pembinaan. Kami merayu muslimin dan muslimat dapat membantu kami untuk merealisasikan impian kami dan kesalahan buat pelajar. Kami masih memerlukan pembelanjaan sebanyak RM900,000.
The amendment saya belum check.
You will find out and see when they're supposed to reply.
Okay.
See whether the time has passed or not.
Okay.
If the time has passed, then you will call them and answer. That's one. Number two, today for the
webinar,
for the conference, you're using
Even the COVID,
Ministry of Health one. You're using which one?
The academy. Academy, yes.
Because I'm using our college one as well.
Yep.
Okay. Thank you. Bye.
Right.
So it's okay. I can use the college one.
Yes, you can use. But I think I'm not sure because Dato Paras have setting a meeting on 3 p.m. I'm not sure the one is he using the college one or not. I will ask.
Using the college one.
I will try ask Dr. Paras first whether he using our college one or he using his one.
I already called the meeting already.
Oh, you already called the meeting? Okay, no problem. I will tell.
Just tell him now.
Okay.
Thank you. Bye.
All right, you're welcome. Apa nama heroes? Then
Yasmin?
Dato, shall we start?
Yes. Okay.
Yeah, Dato, I'm here.
Your slides are ready?
Dada, I've already emailed to her and I have it on my share screen.
Okay, then.
Okay.
Okay. Hello, everybody. Okay, I would like to first of all to thank the Academy of Medicine, College of Physicians for actually inviting the ID group for some sort like, doing all this CME for this month of February, and it is supposed to be the last one from the ID group. And I know that we actually had made a last minute change of topics from MRSA to COVID-19, management of hospitalized patients. But I think this is probably, actually I had requested for Dr. Yasmin to do it just timely, as I think everybody is starting to be involved in the care of cases confirmed COVID. Either you are in the public health, in the GP side, private hospitals, and Ministry of Health as a whole. So I thought it's just timely that we recap what's happening for over the last 1 month regarding our care to this group of patients, and what's happening as well in the rest of globally, in terms of the care. But I will not waste much of time. But here we have Dr. Yasmin Mohamed Gani, our ID physician. Okay, she's actually very popular in Hospital Sungai Buloh, and she's very well involved with the care and management of COVID cases in the hospitals, and she's actually very actively participates in ID group to prepare a lot of things. For example, the interim guidelines for the management, the workflow for caring of patients in the hospitals, SOP, and so on. So she's very, very knowledgeable and very experienced, in terms of management COVID cases. And beside that, I think without further ado, I would like to invite her to have her slides presentation, and probably after that we can open, 10 minutes to questions and answers, so that more interactive session after her presentation. With that, Yasmin, it's all yours.
Thank you very much, Dato. Thanks for the lovely introduction. Hello, everybody. Can you see my slides?
Yes, we can see your slide.
Clearly.
Yes, we can see. Yes.
Okay.
Right. Sorry about the last minute change from MRSA to COVID-19, but as Dato mentioned, this is the apt time for everybody to know a little bit about what ID physicians generally are facing with, and hope with a series of similar presentations, we can get you up to par to what we think is actually happening. Sorry?
Yeah.
Okay.
Go ahead.
All right. So this is a slide courtesy of CPRC. Very nicely puts the clinical criteria and the EPIC criteria, and a lot of hospitals I know are basically managing even suspected cases and probable cases now. Once chest imaging is suggestive, a significant epidemic contact. Sometimes we are more than often are starting to use RTK antigen to diagnose these patients. And of course, RTK antigen is only 80% 80 to 83% sensitive. Most of them will require RT-PCR, so we take them from there. And this is the current category that we are actually using to treat our COVID-19. So clinical stage 1 are asymptomatic, 2 symptomatic patients with no pneumonia. Difference between 2 to 3 is basically just a chest x-ray, and the presence of pneumonia puts them as clinical stage 3. And more severe illnesses are basically those who require oxygen, and of course those who go to ICU and develop multi-organ failure. Now, we know now that we are more confident regarding the pathophysiology and the natural history of COVID-19. A lot has been written by it. So basically, early infection is more upper respiratory nasal colonization. Here, as we know, the virus uses the ACE2 receptors, which is basically very concentrated in the upper nasal, very concentrated in the upper nasal, and it gains entry there. But a little majority of patients go into a very self-limiting flu-like illness, and the disease stops there, right? But when the virus starts going lower, invading the lower respiratory tract and goes to the alveoli and uses the same ACR receptor to enter into our host cell and start replicating, we will start seeing this thing called the pulmonary phase. So the pulmonary phase is where you will start seeing chest X-ray changes, CT changes, and sometimes patients starts progressing and requiring more oxygen, that kind of thing, right? So the initial immune response is basically interferon mediated. So the infected pneumocytes will start releasing interferons. And when in most patients, this is also self-limited, in most patients, this is also self-limited because that small immune response, that limited immune response is enough to contain the disease. But in certain patients, it progresses and then they go on to more significant phase, which is a hyperinflammatory phase, normally characterized by patients requiring minimal to high amount of oxygen support and maybe going into a ventilation. Sorry, hold on. Right. So this is another way of looking at it. Stage 1 early infection, stage 2 pulmonary phase, stage 3 hyperinflammation. And generally what happens is the oxygen saturation starts coming down. All right, now when the oxygen saturation starts coming down, they enter the pulmonary phase, go into a severe pneumonia, and it progresses down from there. During this time, we do believe there may be very high viremia in the initial stage of the disease, but as the viremia starts coming down, an inflammatory response seems to be triggered. All right, and most often than not, what starts happening is so we need to time our intervention. So we know now timely interventions are important to, in vast majority of cases, to see success to treatment. So it's important to capture these patients when they require the oxygen test. Sorry, this is not very clear. I don't know why, but what I'm trying to say is think PCP-like illnesses without much cyanosis, all right? So these patients have what we call as exertional dyspnea. So what we generally do in the hospital is actually, later I'll go through monitoring guidelines, we actually do monitoring exertional dyspnea test, which is a 1-minute sit to stand test. So patients can do it on a nice dedicated chair for patients, or they can even do it at their bedside. Okay, and of course, patients who cannot do it or already oxygen requiring, we don't ask them to do. And what we generally look for is a 3% drop of SpO2 from baseline. This kind of tells us the patient's already going into the pulmonary phase of the disease. All right. Some patients, all right, they will have that. Some patients will show an inflammatory response also timing in time with the drop in saturations. These patients, CRP. So there was a recent scare in my hospital where they say, hey, CRP sudah tada lah, I cannot do any more CRP. Picked up the phone to the microbiologist and basically told her, I cannot treat COVID without looking at the CRP. So it's actually very important for us. So we, in the guidelines, we've nicely stated raising CRP or a single value of more than 50. In Sungai Buloh, it's 5 milligram per deciliter. In most hospitals, 50 milligram per liter to decide whether the patient's actually going into pulmonary phase or not. In some patients, the CRP is not increased. In these patients, sometimes we look for alternate alternate markers that actually tells us, hey, the inflammatory phase is starting. So we look at the NLR ratio, not particularly just NLR more than 3.13, but an increasing neutrophil count or a high ferritin or a high G dimer, whatever, also tells us that maybe a hyperinflammatory phase is starting. All right. Now, this is what our outcome looks, this is basically what's been happening in the first two wave, the first two wave, not the third wave. We haven't looked at it, but the first two wave. Here, 6%. So what happens is once they get infected, almost 50% of the patients no symptoms, and then the infection stops. Out of the rest of the 50% of patients, 88% of them develop very mild, moderate disease and they recover. This is what I was trying to say. And about 11% of patients, they go on to develop severe disease, and of them, 62% seems to require critical care, right? So let's look at the mild ones, but at the moment, what's basically happening, the asymptomatic, symptomatic, current, this one is we are not really admitting, except for if the patients are between, they've divided it into public health has basically divided it into ages. Generally, anybody 60, over 60 with comorbids, they all get admitted. Anybody over 60 gets admitted. The 40 to 60, they will look and see whether they belong to a high-risk category or not. And some of them get admitted to a step-down center. So in the mild category of disease, in the first 1 and 2, it's important to so often what I see is there's a lot of confusion out there. There's a lot of confusion out there. So now we're saying some patients, tak payah masuk, you just stay at home, right? So the younger ones, the less than 40 years old, or even the ones in the 40, 60 got no comorbids also. Sometimes they have the option of staying at home, isolating at home, right? And often at times what happens is patients don't know how to do that. So this is a very nice infographic which was released by University of Malaya that basically tells us what we need to prepare the patients for. Okay, so use a dedicated room, don't eat with people outside, be separate, use a dedicated bathroom, but if you don't have a separate bathroom, clean after you do that, disinfect all the frequently touched surfaces, and always be at home, don't go out shopping, and of course, advise to wash everything separately. Okay, and basic infection control measures like hand hygiene, respiratory hygiene, and of course, how to wash your hands, when to wash your hands. So, and not only that, there's also a caregiver role in the home and the management of patients, and also tell them exactly what are the warning signs are they supposed to watch out for. All right. So symptomatic patients without pneumonia, last time we used to admit everybody into hospital. Now we only admit patients with high risk factors. Isn't it? Some 40 to 60 get admitted. Some centers, more than 60 gets admitted, depending on your state's practice. All right. So in the ward, what we used to do is we do vital signs monitoring at least 8 to 12 hourly. All right. So BD is one of the most common. BD, they basically get minimum BD vital signs, and the doctors actually review them BD as well. All right. And whenever the doctors review them, they look for warning signs. So in terms of, we will go through later what the warning signs are. So later, in terms of blood tests, everybody basically gets a baseline blood test, depending on what is available in your center. So we do a full blood count, renal profile, liver function test. I know sometimes CRP takes a long time to come back in certain hospitals. So LDH can be used, and of course, a random blood sugar, when they come. And if the patient develops any warning signs, we repeat these markers. And as indicator, of course, we do a chest X-ray for most of these patients at first presentation, and if they develop any warning signs. And of course, those who have history of heart disease or advanced age, we basically, anyone more than 40 years old, we actually do a baseline ECG for those with risk factors and repeat as necessary. And of course, these are pneumonia. So the third group I'll be talking about is symptomatic with pneumonia. So 92% of patients actually have mild disease. All right. And stage 2, stage 3, stage 4, the other milder ages, They are admitted with mild disease, but then they subsequently deteriorate. About 8% of these patients actually deteriorate and develop more severe illness, right? So let's go through some case histories. So 41-year-old male, no known medical illness, fever for 5 days, no shortness of breath, blood test, whites count 6, platelet 200, absolute lymphocyte count about 2.3. Okay, this is Sungai Buloh. So CRP 60, 40, I apologize for not converting it, 60, 40, and then 40 again, right? Rest is normal. Okay, this blood pressure is 120/72, pulse rate is about 70, SpO2 100% on room air. Never needed oxygen. Patient never progressed, and actually CRP on discharge actually came down. All right, and patient was actually discharged very well at day 10. Sorry. Apologize. This is your value. This is your milligram per liter. So 6, 4, and 4. So mine will be 0.6, 0.4, and 4. Apologize. So that means CRP never elevated. This person is a 44-year-old female, dyslipidemia, obese, fever for 5 days, and having URTI. No shortness of breath. Blood test basically shows whites count 5, platelet 280, absolute lymphocyte count is 2.5. CRP baseline was 3.2. Blood pressure was 140/57. Pulse rate is about 70. SpO2 day 5, no exertional dyspnea. This was the X-ray, all right, on presentation. All right, so COVID-19 treatment. So who are the patients that you're actually going to start treatment? So let's discuss these two patients. These two patients, who would you give favipiravir and who would you not give favipiravir? Generally, in treatment category 3, no treatment is actually required. This is what the guidelines say. All right. So we say closely observe them for vital signs and treat with favipiravir as category 4 if the patient has any following risk factors. Age more than 50, end-stage renal failure, consult ID physician, and in the presence of any warning signs, right? So, so should we give antivirals? So the category, so the question is, should we give antivirals for everyone? The first case actually had no inflammatory signs. The second case actually had also admitted with not much inflammatory signs, but already had but had some evidence of pneumonia already, right? Right. Like I said initially, 92% of patients actually have a mild disease. Now, favipiravir is something that we use in category 4 and category 5, and used in category 3 if there's high risk for deterioration. More than 50 with comorbids, end-stage renal failure, those with more than one warning signs. Is favipiravir effective? Is the question in everybody's mind, right? So higher dose is tolerable, faster clinical care. What does the evidence say so far? Evidence basically said that higher dose is tolerable, there's faster clinical recovery, but it's not inferior and resolution of symptoms compared to SOC by day 7. So faster clinical recovery. Some studies also says there's faster viral clearance and progression needed oxygen at about 20 to 28%. You can argue and say this is the natural progression of the disease, all right? And it's got a good tolerability profile in end-stage renal failure on regular HD based on 3 papers that came out from Japan. Another meta-analysis paper that actually came up, which said that clinical deterioration was less seen in favipiravir group. But when you looked at the confidence intervals, sort of surpassed 1 line. So this odds ratio may not be, so the data may actually be not very accurate. And it also says oxygen support requirements and not invasive ventilation was not significantly different between the two group. However, we know it's a safe drug. Doesn't have much serious side effects, apart from some GI disturbances and hyperuricemia. And these are elevated transaminases, which we generally see, and very rare reports of neutropenia. There are some drug interactions that we need to look at. And of course, this drug is actually contraindicated for women of childbearing potentials or those who are pregnant. So if they are planning to, impregnate or get pregnant, they are actually supposed to use contraception after finishing the favipiravir use for about 7 days. And of course, there's no data. There's no data if someone's creatinine clearance is actually less than 30. And because it's not a registered drug, we actually require the patient consent to actually administer these drugs. And what do we know? We do not have remdesivir, but even remdesivir, if you look at it, Solidarity study and the NIH study basically said the support is, the benefit is majoritarily seen in those patients who actually require oxygen, all right, rather than those who do not require oxygen, yeah? And when we look at the study in a bit more detail, the benefit was actually more for patients who were started less than 10 days of illness. So that means early rather than those started more than 10 days of illness. All right. So when you look at international guidelines of favipiravir, they recommend the use of antivirals in patients who basically require oxygenation. So each NIH, WHO, as well as IDSA basically says patient require oxygen, then yes, we see a benefit of using antivirals. Okay, so this will in future give us sort of a clue on which are the patients that we will recommend. So who are the patients who are admitted with mild disease, but subsequently they start deteriorating? All right, so when we look at our clinical data, this is the REMCAP data that we collected nationally, who gets severe disease. As you can see, as the age advances, right, the percentage of patients who develop severe disease are higher. So we had a national paper that said an increase, it's almost 8 to 10 times more higher if your age is actually more, your risk is higher if your age is actually more than 50 years old. And when we look at this, same thing, as you can see, patients with comorbid who are around 40 to 60 years old, the risk of getting severe disease and deteriorating is much higher compared to those who actually have no comorbids. All right, and this paper that we published also looked at, actually, when you look at each comorbid, the history, patients with end-stage renal failure or chronic kidney disease have 17 times more risk odds ratio of actually developing more severe disease, right? So what are the warning signs? Fever, exertional dyspnea, persistent cough, persistent symptoms, patients who are tachypnic, patients who are hypoxic, patients who have exertional hypoxia, this and the rising CRP and a dropping absolute lymphocyte count and a neutrophil lymphocyte and increasing neutrophil lymphocyte ratio is, and of course, radiological evidence of severe pneumonia is more likely the kind of people who belong to this 8% who deteriorate. All right, and this is a paper that we haven't published yet. This is looking at the validity of the warning signs that we actually are proposing in the guidelines. So identification of warning signs in patients progressing to severe disease in COVID-19. It's still, we've finished the analysis, yet to share it with everybody, but I just wanted to show the analysis that we got. So these are basically patients from Sungai Buloh, Malacca, and Lahad Datu. We looked at 228 patients who were admitted at early with mild illness and looked at their risk factors of deterioration, hoping to show everybody, actually we make sense when we say that. So the median day of deterioration, that was about 10 days between patients, and univariate analysis showed presence of fever, high mu score. We use mu score, early warning scores, modified early warning scores in Sungai Buloh, and these 3 hospitals use the same as well. Increased zone of chest X-ray involvement, CRP more than 50, and an NLR of more than 3.13 was actually associated with deterioration. However, in multivariate analysis, only higher mu score and the presence of 2 or more comorbids with a high CRP was associated with deterioration, had high associations of deterioration. So in our guidelines here, pneumonia not requiring oxygen. However, in the presence of risk factors, we propose monitoring these patients more often about 6 to 8 hourly, and if further clinical deterioration, increase their frequency of monitoring by the doctors, increase the frequency of monitoring, and a minimum of 3 times a day, the patient should be seen by doctors. And of course, we tend to repeat the bloods daily, especially if there are any warning signs or as indicated, and baseline ECG for patients with risk factors. And repeat a chest X-ray if necessary. So the same case. So that lady came 56-year-old. She's CRP was just 30 and had pneumonia, right? So she came in at day 5 of illness. At day 7 of illness, the CRP was 30. At day 8, it was 34. Day 9, 40. Day 11, 70. Day 12. So day 11, it was 70. She required, we started on favipiravir as based on guidelines, and at about day 11 of illness, which is the median time that these patients actually deteriorated, we actually saw that these patients, she developed exertional desaturation about 3% down to about 93%, and we started on oxygen. We started on Dexa 12 milligram daily, and the patient responded very well. All right, so this was actually the chest X-ray on baseline, and this was the chest X-ray when the patient was actually started on dexamethasone. It's a typical kind of finding that we actually find more periphery involvement of the chest X-ray of the infiltrates, right? Basal to periphery involvement of the infiltrates. All right, and now we're basically, I'm just going to touch on category 4, which is symptomatic pneumonia requiring supplemental oxygen. Now, this is the phase that most of us struggle with. A lot of patients are from the community, so they actually come in quite late, right? Many often than not, these patients come in requiring oxygen already. There is this school of thought saying that these patients may still have some viral response phase, but most likely when they come a little bit advanced by day 10 onwards and they're requiring oxygen, it is possible, it is not wrong to think that the viral response phase is probably trying to taper off, and the patient's post-inflammatory phase is actually starting. So this is the dexamethasone recovery study, which basically only after this, WHO released their guidelines for steroids and says, yes, steroid works. And in that, they also released a statement by saying, of course, there are conflicting thoughts that patient might still be in viral phase. However, usage of dexamethasone definitely saw better outcome in patients receiving oxygen. However, if patients are not on oxygen, and usual care was actually better, and starting dexamethasone too early may actually cause a lot of problems. All right, but if you really look at and filter out, sort of tease out your recovery study, you will actually see that they did not report on patients who were so the dose they used there was 6 milligram daily, right? And two things came out. Number one, they didn't report on patients who were very severe, right? There was not much data released on that. The second, we also show that a lot of patients, there was still a significant amount of patients who actually died, even though they had dexamethasone, right? So I want to share with you all the lessons we learned from category 4 patients, and I hope this will help you all manage your patients in consultation with some of your regular ID physicians. So lesson 1, all right, some switch off with a short course of dexamethasone, all right? So we have a lady, 40, sorry, I don't know why some of my headings are missing, okay, but I went through the slide, okay. So 57-year-old lady, diabetic hypertensive, comes in with day 4 of illness, CRP is 12, not requiring oxygen. We actually started her on favipiravir and she had fever. Day 8, we see a huge jump in the CRP. It went up to 36 to 60. From 36, it went up to 60 gradually. Ferritin is very high. These are all inflammatory markers. Is very high. All right. Absolute lymphocyte count. It is useful in certain to mark and see whether the patient's if it goes down, but it doesn't really predict whether a patient's going into CRS or not. It's not very useful, right? A lot of analysis showed ALC is not very useful to predict that, right? So then of course, she started requiring oxygen. She desaturated. Of course, by that time, she had already completed her favipiravir or had one more day to go. So we started her on Dexa. Immediately after we started day 11, day 12, you can see there is a bit of lag time in the CRP, but subsequently CRP nicely came down. Clinical improvement is drastic. All right, we see this also. Sometimes in the acute phase, the CRP might linger around before or even increase a little bit, but clinically this patient got very much better. All right, so and we never needed to increase the dexamethasone at all. This patient was actually discharged at day 14 after 48 hours. CRP nicely came down. Dexa given total 10 days. All right, and this was the day 8 when we started the steroids, and this was actually at day 12 of illness. It was actually reported patient was getting better. And then this one, lesson 2, sometimes we need to titrate up the dexamethasone dose depending on the severity of inflammation. We learned this very fast. We learned this that a blanket dose of 6 milligrams doesn't work for all patients, and many a times there was so much of webinars about VCs between us discussing whether we should actually be using titration doses. So this is a 58-year-old diabetic and hypertensive, presented at day 9 of illness, low absolute lymphocyte count, LDH is 240, NLR was 12. All right, so started seeing a little bit of infiltrates here on the X-ray, right? And here came in with a CRP. CRP was 12, and then day 10, day 11 of illness, CRP went from 12 to 24 to 48. Ferritin was in the 600. D-dimer was only 199. Patient already required oxygen. We started a Clexane, added Dexa, 8 milligram stat, and then previously we were using 4 milligram BD, but now we know dexamethasone is a long-acting drug, so you can give it once a day. So we give it once a day. CRP continued to rise from about 48, it went up to 123. During this time, patient required similar amount of oxygen, but patient became more tachypnic, more tachypnic. So we gave a total 12 milligrams of Dexa. Was already given 8 milligrams and then 4 milligrams the next morning, right? So total 12. This time we were not comfortable during these times to actually use methylpred in the ward. So what we did was we increased the Dexa dose to 6 milligram BD. So total daily dose was 12 milligram. Just by increasing the amount of Dexa, the patient's CRP continued to improve and she continued to get better. All right, and she was weaned off oxygen at day 5 of Dexa and tapered off and stopped at day 8. All right, lesson 3. There may be some patients who are dexamethasone failures. All right, so we've got a 57-year-old diabetic lady, breast cancer before, day 7 of illness, required nasal prong 3 liters on admission, clinical category 4, given dexamethasone 8 milligrams and on day 1 of admission because you already required oxygen, right? Started on the cocktail of favipiravir and Clexane, and desaturate, and she continued to desaturate. This time more dramatic than the previous case. So she desaturated further and required face mask 5 liters oxygen within 24 hours. All right. So came in with a CRP of 118, went on to 122. So it continued to go up, but we were not comfortable. All right. So this patient started requiring more and more oxygen, and the chest X-ray showed more severe infiltration. So at this point, we were very worried, and with our resources, all of us don't want our patients to get intubated, right? So we decided, we had some procalcitonin kits, so we do get on and off, we do a procalcitonin, and we upgraded dexamethasone to 150 milligram. During this time, we started seeing more and more response in our patients who are admitted in the ICU, and we see how when we admit to we used to give them Dexa, and the patients deteriorate so fast. The minute they go there, they give a minute dose of Metabolite, 1.5 to 2 milligram per kg, and the patient within 4 days comes out back to us. So we started seeing a better response with Metabolite, and we got more and more comfortable using Metabolite in the ward. So we started using Metabolite, a small dose of 1.5 milligram per kg per dose, and we started seeing response. As you can see, CRP nicely went down, patient went into room air, and once Metabolite was used, and once the patient was comfortable enough, we switched it to a tapering doses of Dexa and slowly tapered patient off, right? And this was the X-ray when the patient actually required Metabolite 150 milligrams daily, and then this was 2 days later when we see a nice clearing of the X-rays. All right. Now, lesson 4 is it's all not just about the steroids. All right. It's also about the other supportive therapy that we generally expect and see in these patients. The pathophysiology of hypoxia, if you read several papers, is complex. It's not just about pneumocyte damage and neutrophil and CRS, which is the cytokine release syndrome, or a hyperinflammatory phase that happens where you actually get sequestration of all the cytokines and the neutrophils leading to lung damage. You also see enough has been reported about the vessels supplying the alveoli having multiple microthrombi. So it's not just that, it's not like the alveoli is damaged, but the vessels supplying the alveoli actually, the blood supply is not very smooth. So we call it microthrombi. And I'm not lying, there's been a lot of studies that has been, this is a New York study that looked at their massive cohort, all right, and they saw that that significant amount of thromboembolism has happened from PE to DVT to stroke to MIs, and they may actually be arterial or even venous in certain cases, all right. And when we looked at, when they looked at who are the patients who actually require, who develop these thromboembolisms, and they tried to risk stratify D-dimers, all right, and they looked at the risk of thromboembolism is a bit higher as the D-dimer is increasing, is increasing D-dimer. A single value, I cannot give you a single value, but if you have a condition where the patient is actually worsening and you are able to quantify your D-dimer, right, then always think about whether this patient's having a thromboembolism or not, and start them on low molecular weight heparin. Recently, the effect of there was also another paper that looked at the anti-inflammatory effect of low molecular weight heparin, all right? And in some patients who have very high lymphocyte count, looks very viral. There's no cytokine storm there. It looks extremely viral, all right? Lower the IL-6 level, and you see a very high lymphocyte count, like in dengue, you know, the lymphocyte count is like 40–50%, but the CRP is low, the ferritin is low. Of course, we tend to correlate CRPs with low IL-6s as well, and the patients not treated with, and these patients actually were more likely will benefit from some low molecular weight heparins. All right, and consider full-blown PE if you have increasing D-dimer, worsening hypoxemia, you know, you get an echo, you cannot do a CTPA, but you do an echo and you see a right heart strain, and or those end-stage renal failures, or patients who are actually on lines and they keep clotting, you see. So think of this as a sign for you that this patient may actually have some embolism or hyperthrombotic state from the COVID-19 infection. So this is basically, this is proven. So prophylaxis, we routinely start in all patients who require supplemental oxygen. We give them 40 milligram daily depending on renal function. And of course, full dose anticoagulation, enoxaparin 1 milligram per kg 12 hourly, we also give. And a high prophylactic dose. This is the part that is not 100% clear there, but we do practice this where we actually give high prophylactic dose in and anticoagulation to these patients, all ICU patients. And lesson 5, which is also an important lesson, is don't start DEXA too early. All right. So we have got a 48-year-old man, diabetic, day 6 of illness. Last 2 days prior to admission, worsening cough, comes in with needing oxygen. CRP is 1.3. So sorry, 1.3 is so it's 13 to 23. Ferritin is 182. White cell count, this is what I said. Lymphocyte percentage is actually very high. Right? So at these patients, they were started on favipiravir and given 1 dose of interferons. All right. We used to, there are 2 or 3 trials out there that shows addition of interferon to favipiravir may have some increased antiviral effect, and the patients were their outcome was better. Of course, these patients, as you can see, the CRP was never high. So this patient never high. It really looked like this patient was in full viremic phase. So no steroids were actually started, and patient was discharged well on the 19th. And the same case where we did not realize, that this may actually be a viral effect, but because the patient required oxygen, but the CRPs were very low, 24, 10, 15, all right, and the oxygen requirement was there. Because the oxygen requirement was there, the clinician actually added on DEXA, all right? But what actually happened was the inflammatory phase started much earlier. Without realizing this, then the neutrophil count only started going up around 8 to 9 days, around day 9, day 10 of illness, and the patient required much more oxygen, and we had to resort to methylpred, and the patient actually progressed to ICU care later, all right? And of course, other therapies like statins, more and more pathophysiology of COVID-19 pneumonia is being written. And one of the other contributor towards hypoxia is the microangiopathic changes that is actually seen in the vessels supplying the lung, and statins and aspirins may actually have a role in helping with the thromboembolism, with the improvement, with the outcome. And of course, of recently, ivermectin is something that has been quoted in Brazil. I think they did it in Bangladesh as well as Brazil. And currently, there are many randomized controlled trial. And ivermectin is starting like what hydroxychloroquine earlier started, where they think faster recovery, time to improvement, clearance of virus, and it's been proven in certain patients. And of course, I don't want to talk too much about tocilizumab, but a RAMCAP study, REMAP-CAP trial that was recently released actually showed addition of tocilizumab in patients who require ventilation early when patient required ventilation or NIV, relative reduction in mortality by 24% and reduced mortality, absolute mortality by 8.5%. And of course, this is every time I see a CAT4 patient, I tell them, do not forget to prone. So we routinely have posters like this around the ward, and sometimes we send it to patients also, and these patients, and we tell them this prone positioning has got maximum effect as it improves the oxygenation to the lungs. All right, and we teach them how to do it. So I know it says 30 minutes to 2 jam, do a jam, but what generally I tell patients is, as long as you can prone when you are awake, please prone. If you can do it 30 minutes, do it 30 minutes. If you can do it 2 hours, do it 2 hours. If you can do it longer than that and you're comfortable, go on proning. Many a times with just a low dose of steroids, we may or may not start antibiotics, good dose of, appropriate dose of Clexane, and by proning patients, we were actually able to get them off oxygen. All right. I also wanted to end this slide. This is my last slide. I wanted to talk about an upcoming free webinar series of COVID-19, where there's going to be a series of lectures being announced regarding COVID-19 management, which we hope all of you will be involved. With that, I end my talk. Thank you.
Okay. Thank you so much, Yasmin. There's so much of information to actually swallow for everybody. So shall just see whether I can open up the discussion for you to answer. There are actually a few questions had been posted. Can you just open up to everybody else first and see whether, anybody wants to pose a question to Dr. Yasmin as regard to her presentation or other things as long as related to COVID management?
Shall I start answering them, Dato, one by one?
There's three questions. Yeah, there's three questions. We can start off with, yeah.
Okay, so question one says, in patients requiring oxygen supplementation, is it safe to assume that patient has already progressed to the inflammatory phase of the clinical disease? Would it still be beneficial to give antivirals? I always go back to our guidelines. So that's why I presented it that way. Antivirals seem to have an effect in the early early phase of the disease. So in patients who actually go into a hyperinflammatory phase, granted, there may be an overlap of viral inflammation as well as hyperinflammatory state. So you have to closely look at the patient. If you're saying somebody is deteriorating more than day 10 and day 11 of illness, where they go into when we know hyperinflammatory phase is going to take place, right? So when you go there and everything else supports a hyperinflammatory phase, neutrophil component is high, CRP is high, oxygen requirement is high, in centers where you can nicely get an IL-6 is high. I doubt starting antivirals there is actually going to have any benefit. But if you have a patient and you're diagnosing this patient goes into an inflammatory phase a lot earlier, day 6, day 7, and you tend to think and look at the parameters. Sometimes the neutrophil component is on the upgoing trend, but lymphocyte might still be high. These patients may not have very high CRPs. It is probably okay to give a trial of antivirals. But when you look at Favipiravir study, you can see we don't have intense data. We are planning for a nationwide data to collect data on Favipiravir to see whether it works or not, right? But if you look at the standard evidence that's out there, it is not. It seems the evidence, the benefit seems to be when you start it early, not when you started late, right? Only remdesivir has actually has got some evidence that says that when you start it, when patient requires oxygen or just before intubation, or patients early, less than 10 days of illness, it seems to have any benefit. Data like that is lacking for Favipiravir. So my suggestion is start it in the first week of illness and look very hard for this one, for CRS markers. Is that all right? Dato, shall I carry on?
Go to the second questions.
Oh, suddenly
looking at the use of dexamethasone failure, even not respond to Metabolite 2 mg per kg, more patient requirements are Metabolite 500 OD times 3 days, 250 OD. Does that mean it's a tapering down of the regime? Which probably we have not looked at that. So how to taper the steroid and Dexa comparing to Metabolite, I suppose that's what he meant.
Yeah. So I don't know whether Dr. CK has given you all a talk or not. She's probably much better at this, but I agree with you. All right, I agree with you. I also presented one of our lessons that we learned is dexamethasone is not a magic drug for every patient. So when you look at the recovery trial, they excluded or didn't give us data on very sick patients, right? And when we looked at dexamethasone, a significant amount of them still died, all right? And we do have data on low dose of methylpred. Okay, now this is a controversial question, and no one can give you the right answer. All right, everyone practices differently. When you look at data surrounding methylpred 500 milligrams for 3 days and this kind of a tapering dose, I don't know whether it works. Maybe your we are not being patient enough and giving them enough supportive therapy, and that's why the patients are not improving, right? So generally what happens, we see a patient deteriorating in front of us, we don't even wait for that 24 hours is over sometimes, and we just bang them with another methylpred 500, and we think that's creating. Actually, this itself is it's a question that I can't answer. It's a question that I can't answer, and even any intensivist also can't answer. If they tell you, if someone vouches methylpred 500 milligrams daily works, there's no data for that. But we do know it's a steroid responsive disease, and the most important mantra that we should have is we need to do more studies on the methylpred, look at our own data, which we are doing, and hopefully in the future we'll be able, together with the intensivists, to come up with the response. So data is lacking. I don't know whether this tapering dose, and I don't dare commit to any tapering dose, all right? But generally, supportive therapy needs to go hand in hand when you start methylprednisolone. I agree, some needs tocilizumab. We basically have looked at all our patients that we have given tocilizumab before, and we think it correlates well with CRP and inflammatory. So you don't have CRP, you go for the ferritin. You don't have ferritin or any other inflammatory conditions like D-dimers or whatever, right? So tocilizumab has its role, but to roll it out for the entire nation, it's an extremely expensive drug. And steroid is still our first line. And yes, some salvage cases, we do use tocilizumab.
I think just to add on what Dr. Yasmin had mentioned regarding steroid, I think it is a very difficult situation in terms of regimes, in terms of dosing. You know, for example, the proposal or recommendation of 6 milligram per kg may not be adequate. Some people go higher than that, try to avoid methylpred. But I do see that there are times that patients on methylpred and then converted to dexamethasone, which was actually converted and then tailed down and tapered very fast, may actually have an impact of rebound, organizing pneumonia, that they will discharge and come back again. So these are the patients which is maybe very difficult to predict whom will get this, but I would go for more caution in terms of tapering down the steroid in a very severe cases, you know.
Yeah.
So it may actually have a very fast earlier appointment to review them rather than let them go without any appointment to review.
Most of the time, just like Dato Mahiran says, I think I ignored the last question. So yes, when we taper down, we do see a bit of a rebound, especially in cases that are where you don't think about COVID anymore. It's more than 14 days of illness, and these patients have CT scan evidence and clinical evidence of organizing pneumonia. These cases, we intensely discuss it with our respiratologist and hand in hand decide on a tapering regime. One regime doesn't fit everybody.
Yeah, that's true. So there's a lot more questions, Yasmin.
Okay, is there a role for its direct oral anticoagulants, isn't it? Yeah, for VTE prevention. Or prevention, I don't think so. Prevention, I don't think so. Generally, what happens with direct oral anticoagulants, even from warfarin days, is when you first start, it actually does promote a little bit of thrombosis before it actually goes into. So normally you will have to overlap it with subcut injections. I could be wrong on this, in subcut injections. So generally there's no data for this, but for step down therapy, when someone has proven, we do it lah. Fondaparinux, which is more available. Prophylaxis dose is a bit susah, but there is evidence that there is more paper that's coming out that fondaparinux also can be used in this one. But generally, low molecular weight heparin has got the highest role in VTE prevention when it comes to COVID-19.
Just to inform everybody else, in the series of lectures where we are planning in February, there'll be a special session for just looking at the complications of COVID, and that will include this. And maybe there'll be, by the time, we have more papers on the prophylaxis and also treatments of VTE among the COVID patients. Yeah, so join us that time.
Okay.
So what is the cutoff point or day of illness to start February? Less than 5 days or less than 7 days?
Guideline lah. The guideline says less than 7 days, clinically significant disease, stage 3 of illness, risk factors present, start Favipiravir. I am sticking by our guideline.
Yeah. That is our guideline, based on some of it actually based on our own experience, looking at when there's a delay in start of Favipiravir, we did not see any significant benefits. But I think many papers are actually in the print now, phase 3 trials on Favipiravir, but most of them enroll those less than 10 days from onset of illness. But we will see, the answer by that time. So many actually on Lancet, all this, I see there's a few papers on Favipiravir. I think it will come out soon. Okay.
And we're also doing
RTK versus PCR. What is our stand now?
Okay, PCR is more sensitive than RTK. Everybody knows that, right? Okay, so RTK antigen in a illness which is compatible. You've got a significant pneumonia, right? You've got strong epidlink, right? RTK antigen positive can be treated as COVID-19 infection, all right? But of course, in order to have confirmation, you still need a PCR. But if you have a confirmatory disease, sorry, that's not the word. If you have a compatible disease and a strong epidlink, you can use RTK antigen to call a patient COVID-19.
I think in terms of confirmatory, the MOH has not changed the guideline yet in terms of making RTK as confirmatory for the peninsular. But I think in somebody in areas where there is an outbreak, clusters, for example, factories, I would say RTK antigen is probably adequate to say that this is confirmatory. So I think it depends on the situation. Many calls for RTK antigen as a screening, maybe yes. At present, that's what we do. Like community screening, can we use RTK antigen? I would say yes. But mind you, RTK antigen negative does not exclude these people from not having COVID. So so individual cases need to be, the individual test results need to be interpreted in conjunction with the clinical evidence or presence of clinical features, the epidlink, and so on. But I would agree that RTK antigen may be a better methods of screening, but when it comes to confirmatory, then PCR will probably be better. And now with the availability of the rapid test for PCR, that is another options at the where the result for PCR turnaround time is delayed. It could be a better option to do. rapid test, rapid PCR test, which will need only about, less than half an hour for the test. But when you talk about RT-PCR in our lab, we have a panel of, let's say, 90, 40. So by calculation, you can do a lot more tests rather than individual rapid tests when you have only one manpower. Understand? When you have a test set of 90, one go for 3 hours, compared to 20 minutes for each individual test. So that is more time consuming. Walaupun you tengok that one single test, yes, it's very short, but individually, I think it will take longer time. So we are being very selective. For example, using Gene Expert for certain very acute, severe case that need to go to ICU, where ICU bed is very limited. So we use that, Gene Expert to decide where this patient should go, which bed in ICU this patient should then end up. So that's another option. Okay, hydrochloroquine. We stop. So I can answer that on behalf of him. That's the easiest question so far.
No news.
Yeah, stop for a while until another papers comes out to show there's any benefits. Okay, things progress. A lot of things actually evolving, even our kind of treatment monitoring. So we just have to be more alert about latest update.
I think the previous question before hydroxychloroquine, we've answered it. We don't know. We know Metabolite works. That's point number 1. But point number 2, we don't know what is the best dose of Metabolite, right? Still a lot of, I know practice varies from center to center, but we need more data on this. But at the moment, a good starting dose would be 1.5 milligram per 2 milligram per kg to 2 milligram per kg. And that seems to do the trick for most patients. Okay. Patients post, I move on. Patients post category 4 started on Dexa 8 milligram. How long do you take to taper down? Is it advisable to give low dose oral if they're clinically well to some back? Okay, so when I start patients on Dexa, I make sure it's IV because of the onset of action is actually faster for IV than it is for oral. We monitor the patients closely. Once we think they're responding very well, X-ray is stable or improving, and clinically they're off oxygen, and we look at the CRP levels trend, it's nicely coming down. Patients oxygen free for at least 24 to 48 hours, and all resolution of symptoms, and at least 10 days have actually passed. So they fulfill our current guidelines for discharge, and the patients are well. Yes, we do step down the Dexa to oral, and what is low dose, what is high dose. So oral, and we stop it at, like the guideline says, from 5 to 10 days. We do that. All right. Now, sometimes, like how Dato was mentioning, and one of the questions said, this happens when the patient, this tapering down happens too early. This tapering down happens too early, and the patient's inflammation may not be 100% over. In these patients, sometimes we do go back to a higher dose of Dexa and slowly taper it down. So we learn from the patient's response. So I cannot give you, yes, the answer to this is yes, they're clinically well, you can discharge them oral Dexa and go back. But you also have to do it on a case-to-case basis and look at your patient's response.
Yes.
Sorry, Doctor. Sorry, Dato.
A lot of differences. The last questions. Is there any difference between treatment for category 4 and 5?
Oh, right. Is there any difference? Category 5, LCK. Category 4, Yasmin, sorry. Any difference between treatments for category? It's a evolving a disease, right? Just like if you all understand dengue, you will understand COVID. What is the difference between dengue to dengue with warning signs, to dengue with shock, to dengue with high organ failures and hyperinflammatory phase, right? So we need to cater the treatment according to the category. So most of these Dexas and this Clexane and all will come in as we see that the patient is progressing. Of course, by the time our initial therapy, if it doesn't work and we think we need to change these patients to metapred and a stronger steroids or a more higher dose steroids, which is controversial, we don't know which dose works, and the patient goes on into category 5 and needs intubation, then that is the evolution of the disease. So the timely intervals of treatment is the most important aspect in monitoring, and close monitoring and timely intervention of treatment is what is important that you should take from this from the series of lectures that we are giving. So if we start Dexa too early, it can cause more damage. If we don't, we delay in starting Dexa, the patients can progress very fast. Can hear ka? Sorry.
Yeah, it's very crucial for us. Yasmin, can you hear me?
Yeah.
And yeah, I think what Dr. Yasmin had mentioned, it was true. That category 4 is just like when you have dengue, going to ICU, not yet in ICU, that you really have to monitor and see whether you need to, play around with the dosing of steroid, whether, it's ready 5, the ICU people has to come in, take him to the ICU to be ventilated and so on. So category 4, in that transition to category 5, the best is for them to be actually managed in somewhere, in ICU if the base is available. So be cautioned about the progression. If they're going to progress, they're going to progress very, very fast. Yeah. So be cautioned about that, where to put and place this patient even in the general ward next to ICU and so on. So it's very important. I think we have missed this. Can we put this as a last question and then we close our session?
Okay.
Okay. It's regarding the use of steroid in those patients without hypoxia, but the evidence of the cytokine response is there. CRP persistent climbing more than 50, chest X-ray category 3, not so bad. So is there any role of early initiation of steroid?
Right. So we see this kind of scenario very often, right? We see it very often. So we have patients. So I will go back to the pathophysiology of disease. So I know from all our studying of all our patients, we know the median day of deterioration is about day 9, day 10, day 11, right? And if you get a patient at that point, all right, and your CRP is nicely going up, all right, to a level that you're very uncomfortable with, and this chest X-ray actually shows progressive changes of pneumonia, I do not think, and this patient on top of it has all the risk factors, so you have to take it case-to-case basis, and this patient has all the risk factors of deterioration, and it's showing fever, warning signs are glaring at you, and it's telling me I'm going to deteriorate. There's no harm in starting an early steroids. Most often than not, sometimes, as you know, the SpO2 machine that we use may not be 100% accurate, but we can't go around doing ABGs for everybody. So that's why most of these patients, we very closely do an exertional DSAT test and monitor them before we start steroids. But if you have a situation when you can't do very close monitoring and you're worried that the patient is showing progressive chest X-ray changes, CRP continuously going up, starting steroid early may be a strategy to try and stop the progression. So that's my opinion. We do it, and I know Sabah does it as well. Actually, we were just talking about it just now. Many of us have a similar practice.
Okay, it's 4 p.m. now. I'm sure everybody is quite busy. If there's no burning questions, I would like to actually end our session. And again, I would like to actually pass over to our Secretariat, Academic Medicine. Mina, do you want to say anything to close, or shall we just close the session now?
Yes, Dato. Thank you very much, Dato and Dr. Yasmin, for the amazing talk today. Just one thing, I think there are like almost 20 plus questions. I was just wondering, Dr. Yasmin, if it's not too much, would it be okay for you to type out the answers? What we can do is we can post it in our College of Physician Facebook site. Will that be okay with you?
Can, but all 20, I think 50% of the 27 questions are asking about steroid doses.
Yes, it's repetitive.
Okay,
Yeah.
we've already answered that, and I'm not
Correct,
gonna. I don't think I need to look at it, lah.
Sure.
Sure. I will. How do I do it? I just do it at this setting, is it?
Correct. You can just answer it in the Q&A. I mean, you can choose the questions, Dr. Yasmin. Then what we'll do later is we'll post it in the
got it.
Facebook.
So that means I stay online lah, and Dato leaves
yes, we will stay with you. Yes.
Yes. Thank you.
Okay, Dato. Salam, Dato.
With that,
thank you very much, Dato.
Thank you very much.
You're welcome. So hope see you again next week.
Okay. Okay, Dato.
Okay then. Bye.
Okay. Right. What are we gonna do? Okay. Dexa done already. Category 5. This one is not me. Category 5 is intensivist. Didn't you guys have a talk by the intensivist? No.
No, we didn't.
Okay. We actually plan to do so in our series of lectures.
Yes,
the next. In February, there's 4 lectures all together, and one of them actually is including on the non-active resuscitation for severe cases. So it will be very interesting, but it's under my ICIT and also NIH from KKM website. Yeah, but it will be open to everybody. So we can actually pass the link to the Academy of Medicine to actually invite as well the rest. Okay. Bye.
Okay. Thank you, Dato.
Okay.
Maximum dose metapred or no, I am not going to answer. Thank you for your talk. Category 5. Yes, that's right. Answer live. No, type answer. Yes.
Type answer.
Yes. Just yes lah. Okay. Thank you for your talk. I would like to ask if there any advice how we should taper off steroids. Already answered, right? Prednisolone over. Okay. Some patients develop organizing pneumonia. We routinely suddenly gone. Where is it? Suddenly gone. We routinely discuss these patients with the respi team, and they do start off patients on tapering doses of prednisone. Okay, done. Regards to anticoagulation post-discharge. All right, I'll stop moment to recover. Patients who have high risk of thrombosis, so that means high risk of thrombosis or DVT lah, like bed-bound patients or dialysis patients with blood with lines clotting, may or debilitated patients may require continuation of anticoagulation, all right? Anticoagulations, and thus will benefit from prolongation. Duration is unsure and needs to to be individualized. Is that all right? Okay. D-dimer level. Then I have to press send, is it?
Yes.
Oh, no wonder.
I couldn't.
No wonder lah. Okay. Did you see it? Is it there?
Yes, I see it now.
Okay, this was because I didn't press. For category 4 patients, single most right. This one I think I answered it already. I already said.
You answered 2 questions. Yeah, the other one was the answer is also recorded.
Why do patients still develop PE? God knows. Category 4, probably progression of disease. And the pathophysiology of cytokine storm and the disease itself promotes thrombosis. Okay, then I have to send. Colchicine. My answer is going to be short and sweet. No data. No strong data. Strong data. Short and sweet. Okay. Should we do CRP more frequently in a day? Yeah. Okay. I do practice monitoring CRP twice a day. Sometimes there is an acute rise in CRP, but patient is improving. However, in others, there is progressive deterioration. CRP helps to identify these patients. Okay, all right. What's the other one? How do we know? We don't really see community-acquired infections. See much bacterial infections in the start. Routinely, sometimes we do send cultures and procal. However, after a lot of steroids, secondary rise in CRP, need to consider. Okay, right. What is the other one? Patients reported symptoms. No, 14 questions or more. Okay.
Some of them are repeating on colchicine.
Yeah. Patients reported symptoms. Maybe confusing, I agree. That's the COVID phase. Is there any role for CT value? Possible. Yeah, CT value. I agree. Oh, shit. Oh, sorry. I agree. CT value can be used sometimes. Can be used sometimes to determine early infection, but take it disease. I'm not going to answer this. Any role, timing, don't have, but there's no data. Poor data.
It's okay. It's okay. Yeah.
Yeah. RVD patient on heart, is there a role of starting favipiravir? Instead of their own heart, don't stop heart. Don't stop heart. Okay. For exercise test, how frequent should it? What is this? For exercise test, how frequent should it be carried? Low risk centers. We do it twice a day. BD or when patient symptomatic. Okay, what's the other one? More simplified. Hold on. Could you provide a more simplified way of calculating day of illness? Is it day 0 from swab date, then restart at day 0 if patient becomes symptomatic? Otherwise, more continue monitoring. Right. Day of illness should be started day of swab if asymptomatic and or at day of symptom onset. Symptom onset is more accurate. Some patient due to COVID does require, do you consider quarantining this group longer? Right. In patients with severe disease, if they are fit for discharge, we do allow them to go home and sometimes go home and advise home isolation for another 1 week if they are discharged before 14 days. CDC guidelines mention isolation precaution not be necessary more than beyond 3 weeks necessary, beyond 3 weeks as long as they are showing signs of recovery in normal fever for 3 days. Patients, oxygen patients with right discharge and recovery normal fever, patients who, however, subset is sorry. Immunocompromised hosts could be long and should be okay. IL-6 help, yes. Yes, but it is never available real time. Cut off. So far data mentions 30 not. Okay, done.
Amazing. Thank you so much, Dr. Yasmin. Thank you so
Okay.
much.
Okay.
Okay, bye-bye.
Bye, guys. Bye.
Bye-bye. Afiq, all okay?
Okay. Afiq fell asleep.
Afiq, where are you? Has he captured them all?
Yeah, go already lah. I think go already. Can already lah.
Okay, fine. Alright,
We
we're
can
gonna go.
leave, but he has to do the job.
But that's a thing. Wait, maybe I should take a picture anyway of the answer.
So many.